Thank you for listening to Depictions Media Radio.
Hello again. Good evening, good afternoon, good morning. Thank you very much for joining the press briefing hosted by WHO. My name is Fadela Shaib. I am a media officer in the Department of Communication of WHO in Geneva. The topic of today's briefing is how is COVID-19 impacting services for HIV and related health areas, new data and perspectives. We have 4 speakers. 2 are here with me in Geneva and 2 are joining us from South Africa. I will quickly introduce our speakers and give them the floor. In Geneva, we have Dr. Meg Doherty. Meg is director of the WHO Department of Global HIV, Hepatitis, and STI Infections. And we have also with us Dr. Martina Penazzato, pediatric HIV lead for the department. And joining us from South Africa, we have Dr. Mary Ann Davis. She's associate professor, School of Public Health and Family Medicine, University of Cape Town. Welcome, Mary Ann. And we have also the pleasure to have Professor Salim Abdul Karim. He is the director of the Center for the AIDS Program of Research in South Africa. So we will begin with short intervention from our 4 speakers, starting with Dr. Meg Doherty. Meg, you have the floor. Thank you.
Thank you very much. I really appreciate having this opportunity to speak with you and to be here with my colleagues. We've just finished up a satellite, a WHO flagship satellite on this issue, the mitigation of effects of COVID on HIV and other healthcare programming. So we're very happy to have speakers from that session, as well as my dear colleague Martina this afternoon. So I'd like to mention 3 points. And as of today, July the 7th, we know that we were reported at least 11 cases of COVID with 535,000 deaths. And we know that its impact on HIV services and its wraparound services have been profound. From a survey that we have conducted amongst our member states, we can see that now we have 73 countries that are reporting that their risk of stockouts of antiretroviral medicines, or ARVs, and that could affect an estimated 17.7 million people who are taking ARVs during that time in 2019. And among those 73 countries, we have 24 who are reporting having either a critically low stock or major disruptions, and that means less than 3 months of antiretrovirals available. That could affect an estimated 8.3 million people who are taking ARVs in 2019. The causes for these disruptions are difficulties with suppliers to deliver ARVs on time, a shutdown on land and air travel, as well as limited access to health centers and movement of the ARVs around the country. To mitigate this impact on HIV treatment, WHO has recommended a few interventions. One, to use multi-month dispensing and differentiated services to ensure that people would have longer access to their ARVs when possible, but also to ensure that as these service delivery approaches are being developed, that there are actions to ensure that we don't have ongoing problems with the supply chain and to shore up that supply chain. We've also recommended that we apply these multi-month prescriptions to other diseases and to other medications, such as medications for hepatitis C drugs, medications for hepatitis B drugs, and certainly medicines that affect opiate substitution therapy as well, as these are also critically important medicines that have been disrupted during this period of time. So we are encouraging seeing many innovations being taken up in countries, and in some of the countries reported to us from our country offices and regions, we've seen community deposition of these drugs as well as delivery of ARVs by bicycle by people living with HIV. So we know that during times of difficulty, we have incredibly innovative and very, very committed people who are working to ensure people living with HIV have access to their essential medicines. The next point I want to mention is this disruption in commodities and services for HIV comes at a very critical moment in the progress of the global response. The most recent report that was just launched yesterday jointly by UNAIDS shows that we have a stabilized number of new infections at 1.7 million per year, and that deaths have only minimally been reduced from 730,000 deaths in 2018 down to 690,000 deaths in 2019. So although there have been advances increasing the antiretroviral access and increases in treatment coverage, we are far from reaching fully our 90-90-90 targets, and we know that certain populations are being left behind. In terms of new infections, we see now that 62% of all new infections are among key populations and or their partners. We also know that progress is stalling in prevention and testing services, and they're not reaching those people who are at most risk, and that we have stalling in terms of uptake or pre-exposure prophylaxis uptake as well. So we'll have to be working on building back these services in the prolonged COVID or post-COVID era. We also know that, on my third point, that progress has stalled a bit in the elements of advanced disease. WHO has had robust guidance for a long period of time on a package of care for advanced HIV disease. We have recently put out new guidance and guidelines around how to diagnose, treat, and manage histoplasmosis. This could be a very life-saving intervention for those people who are living in places such as the Americas or other indications in regions where histoplasmosis is endemic. So in this post-COVID period, we need to be able to build back better and build back stronger. We need to have systems that are going to be person-centered, flexible, and prepared for the next pandemic. Finally, we cannot have a panic and neglect cycle with epidemics and outbreaks. We need to, with this COVID pandemic, use the momentum that we're gaining in the science and in the service deliveries and in the wraparound health services and in integrated healthcare to be able to rethink and be more clever and come back and really ensure that we can achieve our targets of having an HIV-free future, and to also have to make our SDG targets of controlling the HIV epidemic by 2030. So with this, I'll pass back to our colleague who is running this session. Thank you very much.
Thank you, Dr. Doherty. Now we will move to another important issue with Dr. Martina Pinazzato, who will describe for us the challenges in reaching young children with HIV services. Over to you, Martina. Thank you.
Thank you very much, Adela. And so I will just take a few minutes to really share with you some of the estimates that we found in the global report shared yesterday, but also in the Tree Freeze report that was launched earlier today by UNAIDS and several partners, among them us and WHO. And these reports consistently show, describe a picture where, unfortunately, prevention and treatment of HIV in children and adolescents is lagging behind. We know that as of last year, 150,000 new infections happen in children, really missing the target that we set ourselves for this time. We know that overall, we can expect 1.8 million children that are currently living with HIV below the age of 14. And we know that last year, only 950,000 were on antiretroviral. meaning that only half of the children in need are currently receiving life-saving antiretrovirals. This is clear. These numbers are clearly concerning and require urgent action. And if we don't do something now, this means that we are accepting that children are left behind. Not doing something now means that we accept that half of the children are not receiving life-saving ART. And it means that we are accepting that only today, more than 260 children died because of AIDS-related conditions. Now, we know that our progress needs to happen in identifying them in a timely manner. We know that we have made progress, but we are a long way to go. We know that we are not able to fully implement those interventions that allow us to test, for example, children that present sick or the children of parents that are living with HIV. We also know that we are not fully using the new technologies that we now have available, for example, the point of care for early infant diagnosis. And we know that depending on where we are, we might need to combine these interventions in different ways. And so it's really critical that we define a blend of interventions that is appropriate and tailored to the epidemic context that we are considering. We know that even if children are started on treatment, unfortunately, the numbers that we are collecting from countries show us that virological suppression is still poor and is much lower than the one observed in adults. And that's true for children as well as for adolescents. We know this is the result of several years of suboptimal therapy that we were providing to children. Until recently, the large majority of children were still receiving nevirapine, which is a drug that our adult colleagues have stopped using a long time ago. We know that there are ongoing efforts in countries to really optimize treatment for children and adolescents, and they are really making a move away from this suboptimal regimen. But we know that this is challenging because sometimes drugs are not readily available, and this is certainly true at time of COVID. But as Meg just mentioned, it's really being affected by important stockout, particularly for those formulations that were already the weak chain in the system, like pediatric formulation. However, we have reason to really be more optimistic for 2021 because on June 12th, dolutegravir pediatric formulation was approved from 4 weeks and 3 kilos. And this allows us finally to fully implement the current WHO guidelines that recommend dolutegravir as the preferred first-line regimen for all. We know that this was possible thanks to the collaboration of several stakeholders in an unprecedented level of collaboration and coordination that really helped us to get where we are. Now, we know that what we are doing now is trying to encourage programs to prepare for introduction of these new formulations and make sure that introduction is fast and that as programs do so, really provide the care that children need beyond ARVs, addressing advanced HIV disease, as Matt mentioned earlier, but also providing that more comprehensive long-term view to the health and well-being of children. And I'm just going to conclude by noting that as when we deliver intervention, it's extremely important we consider how we do so. And for children, this has often been based at the facility, but the COVID pandemic is really giving us the opportunity to take these services outside of the facility through the community and implementing things like multi-month dispensing, which Meg already referred to. So I really want to conclude by saying that these are some of the key actions we need to take to close the treatment gap, but we need political support and we need to ensure that children don't disappear from the global and national agenda. And to do that, we really need to speak up and we need to make sure that the community has a voice in this. We can reach an AIDS-free generation, but that's in our hand and we need to act now. Thank you.
Thank you so much, Martina. Now I would like to turn the floor to Dr. Mary-Ann Davis from Cape Town. Dr. Davis, you have the floor. Thank you.
Great. Thank you for the opportunity. I'm going to comment on our findings from the Western Cape province in South Africa, which is the first province to experience a very high number of COVID cases, although this is rapidly spreading to the rest of the country. And what we were very concerned about in Southern Africa and across Sub-Saharan Africa was that we might see extremely high mortality from COVID in people living with HIV. And so we were very concerned in the Western Cape to investigate this using the most robust data that we could. And we were fortunate in that we have quite good data on all our patients that attend public sector services, so that we could link together the data on all these patients with their COVID outcomes. And in those 3.5 million patients in the Western Cape who attend public sector health services regularly, we could look at the risk of COVID death. And we found that there was about a doubling in the risk of COVID death for people living with HIV. Importantly, this is much less than the risk associated with other factors like older age or diabetes. But it did indicate that there was a significantly increased risk for people with HIV. I will be different from two studies that are being presented at this conference, which from the UK and from New York, which showed no increased risk for people with HIV. Those are both studies done in hospitalized patients, whereas our study included all COVID cases, not just hospitalized patients. And when we restrict to hospitalized patients, we may see different effects because patients in hospital are a select group where one has specifically excluded the people who are at low risk of poor outcomes, and so you don't really have them to compare with. We also looked just in our hospitalized patients, and we still saw an increased risk of death, but it was much smaller than when we looked in the population as a whole. So I think there are a few key messages from the study. The first and most important is a reassuring message, which is that I think we can be reasonably reassured that we won't see massive excess mortality due to COVID in people with HIV or with TB. And in fact, our results of a doubling of risk may even overestimate this risk if there is still some residual confounding, because this is observational data and it's based on routine data sources which are not perfect. I think the other important message, though, to counterbalance that is that until now, based on the data that we had, the message was that people with HIV were at no increased risk of poor COVID outcomes. And that meant that they weren't prioritized in terms of COVID testing or COVID management. Whereas our data suggests that although other factors may be much greater risk factors like diabetes, people with HIV should still be seen as a high-risk group and managed as such in terms of prevention messaging, as well as clinicians being particularly vigilant for their outcomes if they are infected with COVID. Some other interesting findings were that we found that this increased risk was both in people who were suppressed, virologically suppressed, and people who weren't, which is curious and clearly warrants further investigation. We think that the mechanism for the increased risk may be different in people who are suppressed and who aren't. So people who are suppressed and have been on treatment for a long time, comorbidities and metabolic effects of long-term treatment may be more important, whereas clearly for people who are not suppressed, immune dysfunction may be important. But it's also possible that even in people with a normal CD4 cell count, the actual functionality of those CD4 cells is different. We found that comorbidities were very important both in people with and without HIV. And I think this speaks to the message that those of us in the HIV community have been emphasizing for many years, which is that as our treatment programs are more successful, we need to be concerned not only about HIV, but also about managing NCDs optimally in our people with HIV. And then finally, a somewhat intriguing finding is that we saw a low risk of poor outcomes in people with HIV on treatment, in those taking tenofovir-based versus other regimens. This is very similar to a recent report from Spain, although our comparison drugs were different because they had TAF as a comparison drug, whereas we don't have access to TAF. We think it's very difficult to interpret these findings because in our setting with a public health approach, people are only on tenofovir if they are either on first line or don't have renal function. And we know that being on second line and having poor renal function put you at risk for dying anyway, irrespective of COVID. So it's difficult to interpret, but our results were adjusted for viral suppression and they were adjusted for renal failure. And we think it's certainly something that warrants further investigation. Thank you.
Thank you so much, Dr. Davis. Now I am pleased to welcome Professor Salim Abdelkarim, Director of the Center for the AIDS Program of Research in South Africa. Professor Karim also serves as chair of the South African Ministerial Advisory Committee for COVID-19. He will share his reflections on South Africa joint response to both HIV and COVID-19. Professor Salim, you have the floor. Just unmute you.
Thank you very much. It's indeed a pleasure and an honor to be with you here. Just to share, just very briefly, some reflections. I think you've already heard the way in which the response to the COVID epidemic in terms of restrictions of people's movement, the way in which lockdowns were implemented, had quite a dramatic effect on healthcare services at a very broad level. You've already heard in South Africa, it impacted access to TB testing and diagnosis. HIV viral loads went down by about 30-odd%. So we certainly saw that impact. As we've eased the lockdown, those are slowly now getting undone, and we are now getting back to better access. But there's a subtle issue that we're really grappling with, and that is that with the initial onset of the epidemic and the way in which it was portrayed and the way in which we saw on our TV screens, the challenges in Italy, in New York City, there's a sense of anxiety. There's a sense of concern. And so a survey undertaken in South Africa by Ask Africa shows that 58% of people are hesitant to go to a healthcare service because they worry they're going to catch COVID because that's where the COVID patients are. And that's something that is a major challenge as we grapple with these combined epidemics. But there's little doubt that in countries like South Africa, and indeed in many countries in Africa, our substantial HIV epidemics have built infrastructure that have placed us in a somewhat good position to respond to the COVID epidemic, whether it's on just the capability to do PCRs at high throughput and volumes. I mean, in South Africa, we can do well over 100,000 PCRs in a day. It's not a problem. We have enormous capacity. We can't get the kits for COVID to do that many, but we certainly have the capacity. But also, just if you take South Africa's initial response of doing active case finding, with 60,000 community healthcare workers in the field, going house to house, going into vulnerable communities and testing people, we've screened over 20 million people this way. All of that with HIV capability. So I think we've seen the way in which these two epidemics have acted, both negatively and positively. As I look at it, when we deal with the surge, which is what we're currently doing in South Africa, we will be going into a phase over the next several months, perhaps even years, until we have a vaccine or a cure, that we're going to need to change the way we tackle COVID and deal with it like the way we dealt with HIV. Initially, we were all helter-skelter, with so much to do, and we were all very busy. And then we said, actually, we've got to be ready for the long haul here. And we've got to look at this disease in that way. We're going to look at COVID in that way. And the way we do that, we're going to start thinking now about integrating some of these activities so that we don't end up building parallel systems which are unnecessary and which really don't build on the synergies that we could have in dealing with many of these epidemics and syndemics in a joint and structured way. Thank you.
Thanks so much, Professor Salim, for these very interesting reflections. Now we will turn the microphone to our journalist friend. We're waiting to ask their question. Please, just to remind you to raise hand if you want to ask a question. This will put you into a queue. I can see that we have already Adam. If you can introduce yourself and ask your question. Adam, can you hear me?
Yeah, hi. Thanks very much for that, everyone. That's great. It's Adam Vaughan here at New Scientist magazine in the UK. I was interested in, especially hearing Mary Ann's comments there about the study. I was interested, is the greatest impact of COVID-19 on people with HIV directly through things like, for the sort of comorbidity that you talked about there, or is it indirectly through the impact on the supply chains for the drugs? And also, I know it's not really the focus of this briefing, but I wondered if any of you can say anything about the sort of knock-on effects of COVID-19 on other disease burdens. We touched on TB. I was also interested in malaria. I just wondered if you could make any comments on that as well. Thank you.
Dr. Davis?
So the findings that I was reporting were about people who died of COVID. So with clear history of COVID symptoms and a positive COVID test. So we're not talking about knock-on effects due to poor access to treatment or due to people not being able to be admitted to hospital for other reasons. We clearly, in our study at the moment, we've just limited to actual COVID deaths.
Thank you, Dr. Davis. Dr. Doherty will take the second part of the question.
Thank you very much. Thank you very much for that question. And I think just like the experts who are working in HIV and looking at service disruption, there are many different programs that are looking at service disruptions and challenges and the knock-on effects of COVID onto NCD programs, malaria programs, tuberculosis programs, neglected tropical disease, maternal health. And I would just direct you to our WHO websites where we have not only the modeling and also some surveys that have been done on NCDs and also the broader health services. Currently, what we're seeing is services, the NCD services, about 70% of those countries that were surveyed had challenges and disruptions in their NCD services. Same for vaccines, same for contraceptive services, dental services. So in many ways, HIV services have been, in those general essential health services, have been noted as being quite essential, and most countries are keeping the doors open for HIV services in much more than others. And there's many modelings that are also estimating hundreds of thousands of excess deaths if there are disruptions in the supply chain or in significant lags in delivery of the care. I would have to say that the impact that Mary Ann Davies is noting in her study is not affected by the supply chain challenges I'm mentioning right now, because that's a retrospective look at what is happening in South Africa. And currently, right now, that supply chain seems to be well managed for the moment. But it's further on, over 6 months or so, that we're going to start to see the real challenges in the supply chain. So her mortality is irrespective of the drugs at this point in time.
Sorry.
I have a question through the chat from Esther. Can you hear us, Esther? No. If not, I will ask her question. She was asking our expert to speak a little bit about the stigma for people living with HIV during COVID-19.
Thank you, I can hear you.
Yeah, you can hear me? Thank you.
Yeah, thank you for asking the question. That's it. Thank you.
Yeah. Okay. So, Professor Salim, maybe you can speak about this subject, stigma against people living with HIV during COVID-19?
Yeah, sure. I'm happy to do so. I mean, there was so much of deja vu when we dealt with the first set of patients that were diagnosed, and the way in which they were treated, just like the way, early on in the HIV epidemic, the HIV patients were being treated. And when there was a child infected and was at the school, you can imagine, exactly all those things came flooding back to me as to how this disease is being treated with this kind of stigma. Now that we've got over 100,000, close to 200,000 infections in South Africa, now there are many people with this disease. Many of those things have dissipated, but not entirely. And when I reflect on exactly the initial challenges that people feel in dealing with the diagnosis, it reminds me of all those same challenges that we had in the HIV epidemic. The parallels are just quite striking. People don't want to go and test, because if they test, then they are ostracized. And it's taken a while. It's taken a while to overcome those things. So now people are willing to readily test because they are driven by different factors, including that they need to know their status because it impacts on all of their family members and all of their contacts and all of the people they're interacting with. They don't want to put others at risk. So I think we are seeing this transition in South Africa. And when I talk to my colleagues in several other countries, they've also seen this transition. One of the important factors we mustn't forget, though, is that in a situation where you have this epidemic growing, there are also other stigmas that play into the COVID stigma. The issues around foreigners bringing this disease to us, the xenophobia that goes with all of that. And so we have to, it's a reminder that we can never let our guards down, that we have to remain vigilant as we tackle the challenge of stigma, just like we did, for COVID, just like we did for HIV.
I will take a question from Jenny, our friend Jenny from DEVEX. She is asking, can anyone comment on what funding avenues are available or being discussed by the HIV community to fill gaps in financing for HIV in the immediate and long term, as COVID-19 is expected to put more pressure on donor budget? Jenny from DEVEX asking this question. Who can take it? Maybe Meg? Thank you.
Okay, for that question. I know this is a bit of a complex area because we're very much at the very beginning of the pandemic, 6 months in, and there has been an enormous amount of effort put into global solidarity around building momentum to address what's happening in countries. And so I think that at this point in time, many countries are willing to contribute very highly to the pandemic, and multiple organizations, as you know, are doing so thus far, as well as multiple countries are doing this, member states. What we do know for the HIV, for the report that came out this year, just shared yesterday, is that we do have some shortfall in our funding, and we have some shortfall in all of our donor activities. And we're looking at some of the countries already. We've just seen a commitment from Germany to provide extra funding to UNAIDS to support an HIV and COVID agenda. And we are going to have to be very mindful that as we look to the funding that is going into COVID, that it also is being used at country level to shore up the systems of HIV. Because most of us will know if you get to a country level, we're seeing that our HIV specific healthcare workers and programs, just as Professor Slim has mentioned, are being repurposed to work for COVID. The laboratories are being repurposed. Healthcare and community care healthcare workers are working dually on HIV and COVID. And so we're hopeful and mindful that at country levels, the ministries of health and the ministries of finance will ensure that the extra funding that they do have for the pandemic are shared amongst the other programs and the general health system. As we move into a longer term view, we're not seeing that we're in a difficult situation where we need to be accessing the same funding or a smaller funding pool. But I can imagine that we're going to have to keep our eye on this as we move forward. But currently, right now, it's not been a major challenge, and we'll have to follow this as we move forward over the next several months.
Yeah, thank you, Meg. We have a reporter from Kyoto News, Japan, Stanley, who sent his question in writing, but we will try to see if he can ask his question. Stanley, can you hear us? Kyoto News, Japan.
Hi, good day to everyone. Yes, I'm from the Philippines, but I am working at Kyoto News, Japan as an international reporter. I just want to ask if we have recent data in Southeast Asia, since majority of countries now started lockdowns, and if there's a difference between the first quarter record and second quarter of 2020, if we have recent statistics about that.
Are you asking about COVID or HIV?
HIV, yeah, HIV.
HIV.
Yes.
So he's looking for recent data in Southeast Asia on HIV.
Yeah, thank you very much. I think this is an pertinent question to have up-to-date data readily available. What we do know right now, the data that we've reported on new infections with HIV, deaths related to HIV, and the coverage of antiretrovirals in the report that came out from UNAIDS and WHO are for the period up to the last quarter 4 of 2019. As we move into the quarter 1 and quarter 2 of 2020, for HIV services, of actual numbers of people on therapy, we don't have those numbers actually at the time. But what we do have is estimations of people who are not accessing their antiretrovirals or those who could be potentially affected. So we have modeling that gives us a sense of if we do nothing, what is the worst case scenario? And then we have the data around drugs that are held up in getting into country, or that there's a concern because their central stores may not have enough drugs. But what you're asking for, we will have to look at that data, and every 6 months to 12 months, we look at that over time. And so right now, we're not in a position to tell you exactly how many people are either off of treatment or lost to HIV therapy in this period of time. However, country by country, you may be able to find that information more readily or in the regions. Thank you.
Thank you, Doctor.
They asked Martina about how this is, and especially in those countries that may have some interruptions.
Yeah, thank you, Meg. So indeed, we are monitoring what's happening in countries, and we know that there is anecdotal reports of service disruption, both in terms of uptake as well as we mentioned earlier, medicines or test kits not being available or being used for other reasons. We know, however, that data is being generated right now, and it's extremely important for us to wait for that information to have a better understanding of the level of disruption. A lot of what's been noted, explored, the models being hypothetical, and we obviously need to keep an eye on the situation as it evolves, because we know it's quite fluid. But certainly a concern around pediatric formulation, something that we are on a daily basis, depending on the key requests that come from countries, both in terms of treatment as well as prophylaxis for children.
Thank you, Martina. I can see that, in fact, we have a lot of participants, so don't be shy. Just raise hand and ask your question to our four experts. If I think I will read a question. He's not a journalist, but he's an academic, and it's a question to Professor Salim. It's from Anthony Zui from Sydney, I think. The issue of thinking longer term and integrating COVID-19 responses with other effective initiatives and system development is important. What is your advice, Professor Salim, on the timing and sequencing of this mainstreaming and integration? I don't know if the question is clear, Dr. Salim, Professor Salim?
Yes, it's clear. I know the question. And it's good to hear from a very long-standing and somebody we were in the anti-apartheid struggle together, Anthony and I. So we go back many years, decades. I think one of the biggest challenges that demarcates COVID from almost any other disease I've dealt with, and I've dealt with many over the years, is just the way, the speed with which it works. In fact, a week feels like it's like 2 months or 3 months. Time sort of stands still because you're doing so much and things are moving so fast. I call this, it's an all-consuming disease. It eats up every minute, every waking minute. And right now, nobody is interested in doing anything else. Those who are, focused on dealing with the COVID epidemic. But I think it's going to need people like us who are thinking into the future, who are not just looking at today's problem, but who are starting today to solve tomorrow's problem. And that challenge is going to be that once we, as now is the case in much of Europe, once we are over the surge and we are into the period of containment where we just see sporadic cases and, we're preparing for the future waves, will come a time when we will really look at this as a marathon. Now we'll understand, we can, at least I can sit down on a Saturday morning and read the paper instead of reading a journal article. And when that point comes, and I think it'll come once we've had a continuous period of a few weeks of very low cases and just sporadic cases, that's going to come a time when we're going to have to establish all the vigilance mechanisms, get them well in place. And in many ways, HIV has created a lot of that capability. I think the big challenge was something that was mentioned earlier, and that is we're really missing a simple test. That was a big leap in HIV, was when we went from having to do complicated laboratory tests to a very empowering, even though it was initially we complicated it, we had to do 2 separate tests and so on. But even then, the fact that you could go somewhere, get an answer in 20 minutes and walk out, it makes all the difference. And it's that empowering sense of, I know where I stand. It's really very important. And now you go for a test. Well, first you got to go all through this awkward swab, which I hate. And then you got to wait for another 2 days to get the answer. So it just is a completely different way in which we deal with these two diseases. So I'm very optimistic. I think as rapid tests become available, and they are going to become available, whether they are PCR-based or antibody-based remains to be seen. It looks like it'll probably be an antigen test in all likelihood. If that happens, then we will have a rapid test for COVID. We have a rapid test for HIV. And, we have capabilities to look for diabetes, measure somebody's pressure, and so on. So I think that's the opportunity. And that opportunity we have to start thinking about now. Even though we've got COVID on the brain, we've got to think about it starting now.
Thank you, Doctor. Good job.
Thank you. I think you are old friends. Thank you, Professor Salim. Now, I would like to invite someone calling from Indonesia who sent her question in writing. You can ask your question, Angel.
Okay, can you hear me?
Yes, perfectly.
Yeah.
Go ahead.
Okay. I'm a CEO of a private sector, and I'm interested to find out, are there any good lessons on how a partnership with national or local government, private, or even artists who can contribute to solution for HIV/AIDS that you can share for us, Thank you.
Dr. Duarte?
Thank you very much for those questions. And certainly there's a lot of excellent and wonderful examples of where community, artists, the private sector come together to make a big impact on the HIV/AIDS epidemic. And so coming to mind right now, I'm thinking of your part of the world, but I would note that there are many different agencies or community CSO agencies that are providing antiretroviral therapy in Indonesia in particular, and they're in the prisons, so they're bridging both the primary care and the Ministry of Health and the prison system to bring antiretroviral therapy. And they're also working within the community organizations. And in particular, I believe it's with those who are transgender and people who men who have sex with men. There are very excellent examples of where you've done a wonderful job of being able to have low stigma settings for key populations, have services that are needed for that population, and provide antiretroviral therapy and STI treatment. So
around here,
we have a number of excellent examples. But around the world, if you need any more examples, we can certainly provide you with links. And we have a whole compendium of what we call key population services, where we have examples of good practices between public, private, and community organizations, including artists as well. So we'll be happy to share that with you. It's online. Thank you.
Thank you. Thank you.
Thank you so much, Dr. Duarte. I think I don't have any question from journalists, but if I may, I would like to ask a question to Professor Salim. Just before we close this press briefing, I wanted to ask Professor Salim if he can share with us some reflection about how can other low and middle income countries learn from South Africa response to HIV and COVID-19, because you have this double hat. Maybe it could be interesting for us to hear this from you. Thank you, Professor Salim.
Sure. I'm sure there's going to be books written on the subject because in many ways, in many countries, especially in Africa, a lot of the capacity and the people who have led the battle against HIV are now in the front lines of dealing with COVID. And so it should be, because those are the individuals who've developed over many years the expertise. I would say that the central issue that I have found is to separate out science from the politics. That as scientists, we must stay true to our science. Because I can assure you, there are many political pressures that will try to define how a country is dealing with this problem. As investigators, as scientists, over many years, we have always stood up for what was right. Whether it was against AIDS denialism, or whether it was, whether ART worked, or however it was, we always stood on the side of science. And we knew that if we did that, we would be making, giving advice, and we would be providing leadership on the basis of principle. And I think today, in much of what I have seen, is where things have gone astray in the response is because the science was not really accepted as the dominant paradigm to deal with COVID. And we saw the same in HIV. When science was not accepted as the paradigm, and when people questioned things, we ended up with people dying. And in COVID, it's exactly the same situation. I've had to deal with this at the front lines in HIV, so I can tell you from personal experience what that entails. But in COVID, you don't have that luxury of sitting and debating with somebody about X or Y. You can't debate with a politician, whether masks are a good idea or not. And there is the science that guides us, and we have to take action. And in my view, I would say that that's probably the biggest lesson I learned. I could go through chapter and verse about, how we think about HIV and how our response to HIV can mold and guide us to have a better response to COVID. But that's for another day.
Thank you, Professor Salim. Now, I think I will ask Dr. Davis if she can see how the outcome of her study in South Africa maybe play out in other countries across Africa or beyond. Do you see any possible trends beyond what you have found for South Africa?
Thank you very much. I think it will be very important for other countries, if possible, to do the same sort of analysis so that we can actually see whether the risks are similar in other countries, because clearly what we're seeing in our setting seems to be different to Europe and North America, although the analysis approach was different. And I think, again, just to emphasize the reassuring message, which is that we're not expecting to see huge excess mortality due to COVID in people with HIV from other countries as well. I would also like to emphasize what Professor Karim has said, which is that the data systems that enabled us to actually do this analysis were initially set up for HIV. And we wouldn't have been able to do this if we hadn't had the robust system set up for HIV, which enabled us to look at this very quickly in our population.
Thank you so much. Thank you. Before we close this session, any of our experts wants to add something? Martina, maybe?
Yes, maybe just a quick comment related to COVID in children. And children that live with HIV, and to note that at the moment we have very limited information. And we know that a lot of HIV researchers on the ground are really mobilizing to be able to document and to be able to collect information that will help us to understand it presents in children living with HIV. We know that in the global data so far, children continue to be less affected by COVID and present milder clinical presentation. However, we know that there are some potential clinical features that do not allow the one in adults. So it's really important we keep monitoring and keep collecting information on children specifically. Thank you.
Mike?
Yes, we noted this a very pertinent and relevant question that came in from the Associated Press asking would the opening and resumption of airline travel help with the antiretroviral disruptions? And I would say yes. We would believe that it would allow us to have many more flights traveling to some of those more distant areas. It's not that we don't have enough drug being made. It's the moving of the drug around that is our main challenge. And so certainly, yes, we would see that as something that would be alleviating. But as soon as, of course, it's safe.
This show has been produced by Depictions Media. Please contact us at depictions.media for more information.